Hello, welcome to our program of digital slide review and surgical pathology sign out. I'm Dr. Louis Hassel coming to you from not Dak Lak province in Vietnam, but from the campus of the University of Oklahoma Health Sciences Center. Our program is part of the Digital Anatomic Pathology Academy, a service of the Digital Pathology Association and PATH presenter. Our case today comes from the realm of gynecologic pathology. The patient is a 56-year-old woman who's been found to have a pelvic mass involving one ovary. So with that diagnosis or concern for possible malignancy, this lesion was removed and brought to the pathology laboratory for evaluation. As you can see, it's a rather bulky, multinodular, irregular mass with variable sized yellowish, tan, and sort of purple red nodules protruding from the surface. And on sectioning this lesion, we found a cut surface that was, again, quite variable. Some hemorrhagic, sort of watery cystic areas, others slightly more fleshy or solid, but again, not really a definitive single area of more conventional carcinomatous type of tissue. So on a frozen section evaluation of this lesion, we were presented with here from one of the more solid areas, a tumor with variable small bands of pink fibrous tissue and intervening areas of more purplish solid tissue, with some variability in terms of nuclear density. As you can see, there's not a lot of heterogeneity. There's no necrosis in this tumor. And on higher magnification, we see this quite compelling sort of small cystic spaces, fairly bland intervening nuclei, a slight degree of pleomorphism to some of these cells. But we could identify absolutely no mitotic activity despite rather lengthy search during the time of frozen section. With this dense fibrous tissue, we were wondering about various stromal neoplasms, perhaps a degenerative fibroma. But this seemed a little bit too cellular for most conventional fibromas. We wondered about sex cord stromal tumors, and again, didn't see any evidence of luteinized cells or any specific tubule formation. Didn't have the classic follicles of granulosa cell tumor or any evidence of tubule formation other than these microcystic spaces. So although it appeared to be relatively low grade, we couldn't exclude some of those potentially more serious lesions. And we said the low-grade stromal type tumor, question sex cord stromal origin. So with that information, the surgeon was able to provide some additional staging biopsies, and we awaited the permanent sections. So what should we be thinking of with a tumor that has sort of a microcystic pattern like this one did? Well, certainly granulosa cell tumors, both adult and juvenile, can have sort of cystic patterns, sometimes microcystic appearance, although usually these are more large follicle type tumors. And they usually have more abundant cytoplasm, especially the juvenile variety. Yolk sac tumor can have a microcystic pattern in a number of settings. Again, but usually those have more malignant appearing nuclei, mitotic figures, and of course tumor markers would have been triggered. In addition, this is usually a younger age group tumor. Sertoli Leydig cell tumor, again, a possibility. We didn't see evidence of luteinized change or Leydig or tubular formation. Some endometrioid carcinomas can have microcystic pattern, as could struma ovariae. And then there's a stromal neoplasm, the microcystic stromal tumor, which of course is classic for having a microcystic pattern. But that's a very rare entity, and so not something that's frequently encountered. So with those things in mind, we approach the permanent sections, and here we see one such with multiple nodules of tumor, Sort of looks like it could be a granulosa cell tumor. Here's more macrofollicular areas in addition to the microcystic changes that we saw. A lot of hemorrhage and so forth, and these intervening fibrous bands. So we'll take a look at some of the cytology of these tumors, of this tumor. And again, we see this fairly bland appearance, sort of lightly vacuolated cytoplasm, round nuclei, no grooves, and areas of interstitial hemorrhage, as we saw in the gross, is replicated here in a lot of hemorrhage associated with these small cystic spaces. We might wonder about epithelial differentiation, a sort of a bluish color to some of the cyst contents. So certainly a possible masquerading tumor with an epithelial differentiation would be considered. And so we began to make a list of immunohistochemical stains that we might consider doing. Here's another section, again showing no surface involvement, cellular nests, lobulated pattern, intervening fibrous bands, hemorrhagic cystic spaces in this tumor. And then as well, this very prominent microfollicular or microcystic pattern in the tumor. Here with a sort of bluish, bubbly, almost mucinous type of an appearance. Again, not much in the way of cytologic atypia and not fairly sharp boundaries between the fibrous tissue and these cellular nests of tissue. Take a look at one more section here. Oh, one of the things we wondered about was granulosa cell tumor. And so we did a reticulin stain to see if that might be helpful to us. And I think you can see here that there is reticulin in this, but the reticulin is not particularly highlighting nests of cells. It's just sort of scattered haphazard. It's not around every cell, as might usually be seen with granulosa cell tumor. It's not highlighting any evidence of particular epithelial type origin. It's really much more haphazard, here some, there some sort of appearance. So this helped us to tend to exclude granulosa cell tumor, although immunohistochemistries that were negative for inhibin, calretinin, and other sex-scored stromal markers were also very useful to us in that regard. Cytokeratins were uniformly negative as well. But we did get a couple of markers which turned out to be positive. So here's one of these, and as you can see, this is a nuclear staining marker. This is WT1, which is staining virtually all of the tumor nuclei. Well, we don't think that this is a serous tumor, but there are a number of other things that, of course, can be WT1 positive in the ovary in an older adult. In addition, we did this marker, which is beta-catenin. And as you can see, it's quite strongly positive. And this is a tumor, excuse me, this is marking both nuclei and cytoplasm. As you can see here, many of these tumor nuclei are very strongly positive, as well as the rather diffuse cytoplasmic positivity that we can see from low magnification. So this immunophenotype is quite characteristic of the microcystic stromal tumor. This is a tumor that has been described as having a somewhat lace-like pattern and really quite distinctive, this microcystic pattern with intervening fibrous stromal bands. These tumors are usually CD10 and vimentin positive, as well as inhibin and calretinin negative, as we've indicated. But the truly helpful things here are the FOXL2, WT1, cyclin D1, and beta-catenin. These form the standard, I guess, by which you would make this diagnosis. This does occur in a wide age range and is usually unilateral. The tumors are mitotically indolent, although there can be occasional atypical cells and variable other morphologies. A few rare cases have been reported with intra-abdominal spread. So the beta-catenin positivity raises the question as to, are there other CTNNB1 mutation positive tumors that could enter into the differential here? Well, one is ovarian solid pseudopapillary tumor, which is perhaps even more rare than the microcystic stromal tumor that we've encountered. Consideration has been given as to whether these two tumors are in fact the same entity, and that discussion may be ongoing for a while. There are a few rare endometrioid adenocarcinomas which have this mutation, but the morphology in those and the immunophenotype would not be particularly overlapping. And in addition, some testicular Sertoli cell tumors have been reported to be positive with this mutation. So there is some boundary for consideration of other neoplasms, but I think both on the immunophenotype and the morphology, we can exclude these possibilities. So there you have it. Our diagnosis for today's tumor is a microcystic stromal tumor of the ovary. Indeed, a stromal neoplasm, but a very distinctive one with generally a very benign behavior to this point. Rare cases of intra-abdominal spread, no cases of metastatic disease or death due to disease, to my knowledge. We hope that you enjoyed that case and that will enrich your differential diagnosis when dealing with some of these challenging ovarian tumors, and perhaps expand the range of immunohistochemistries that you may consider using on some of your stromal neoplasms. If you like this video, of course, we welcome you to subscribe. We invite you to subscribe, and please like it so that others will be also able to share in this somewhat unique and intriguing tumor that we've shared today. So until next time, thanks so much for joining me.